Hi, everyone. I'm John Russell. I'm a head and neck endocrine surgeon at Johns Hopkins Hospital in Baltimore, Maryland. I'm also the chair of the technology committee for the American Head and Neck Society. Um, I'm excited for the chance to be able to speak with you. I certainly wish that I was able to speak with you in person. This meeting brings together many of the world leaders who are able to talk about a lot of the advances that we're doing. And it's sad to not be able to be there with you in person. But certainly let's make the most of it. And today we're going to talk a little bit about some of the incremental advances that we are making as we try to treat our patients with thyroid pathology. Um, I am a consultant for Baxter, but I really want to focus a little bit on what each of us can do. We have some goals of where we want to get. And sometimes when I come to this meeting, I look at so many of you who are doing very advanced techniques and very advanced experiments and things that you're doing that are very much advancing the way that we treat pathology of the head and neck. And for me, specifically, thyroid and parathyroid tumors. And as I watch the things that you're doing, I think, how can I make a difference? And I think this quote by Lao Tzu helps me to understand that each thing that each of us does to advance towards our goals of helping patients is incredibly beneficial. And those small steps that we make add up to get us eventually where we want to be. So what are the goals? What would I like to do if my family, if my mom had a thyroid tumor, what would I want for her? And I would say the first goal that I would have is that we would only treat the tumors that affect morbidity or mortality so that we're not over treating people that don't need to be treated. Instead, we're just treating the right things. And then the second goal would be to heal people with no complications, no scar, and no pain, and to do that for very little money and for as many people as possible. And if we can do those things, those are the goals. And then somehow we get to be just like Bones from Star Trek. You might know Bones. He was the surgeon on the USS Enterprise, and he would heal people, but he never used a scalpel. I never saw a single episode in which he used a knife to cut people. Instead, he would fix people with any number of gadgets from outside, and somehow he always had a trick to heal people. And in this picture, I think he's trying to heal Mr. Spock of his thyroid cancer. But I think this is the sort of thing that we need to be focusing on as we look for our goals. No pain, treat as many people as possible, no scar, do it for cheap, only do the right thing and never do anything extra. And so part of the way that we can do that is we can focus on don't treat the things that we don't have to treat. And so we know some of the data, the international data that has come first from Japan and has now been replicated in other parts of the world. For small thyroid cancers that are within the thyroid parenchyma, it might actually be safer to observe these tumors than it is to operate immediately. And certainly that's a change in our paradigm. It's a change in how we think. But as we do these things, potentially our patients end up with better outcomes. And certainly there are other things that we can do. For example, we can use molecular markers to tell us which tumors are actually cancers. And hopefully in the future, we'll go a step further. And instead of using these molecular markers just for diagnosis, we will also be able to use them for prognosis. And we'll be able to say to our patients, you have a tumor that is never going to become an aggressive cancer, and so you don't need anything. And for other patients, we can say, even though your tumor is small, it has mutations that suggest that it will become more aggressive in the future. And so we should intervene sooner instead of later. And certainly there are other techniques and technologies that are helping, artificial intelligence and ultrasound, so many things that are progressing along this path. I think one of the things that we can think about is machine learning. And you can see an algorithm on the right-hand side about whether or not you should eat food if it falls on the ground. And I think maybe we can use other algorithms to help us find out which people need to have a CAT scan for different things. As you can see, a study that we were involved in looking at which patients needed imaging for vertigo. And as we start to apply some of these algorithms to thyroid tumors and to parathyroid tumors, we end up treating just the right patients in just the right way. So what else? So another one of our goals is to have no complications. And we know that we have fewer complications when we do less surgery. And so the American Thyroid Association has begun to recommend that when you have a small cancer, a cancer smaller than 1 centimeter, you should only do a lobectomy. And if it's smaller than 4 centimeters, a lobectomy should be an option. And you should balance that with the patient about the pros and cons of treatment. But we know that the less surgery we do, the safer our patients are. This is a table that demonstrates that the safest patients are the patients who use a high volume surgeon, that's the green bar, to do a lobectomy, only one side of the thyroid. Those patients are safer. And so if we can move our patients towards fewer complications by specializing and doing more of what we do and doing it better, and doing less of what we do, meaning only do hemithyroidectomies when possible, our patients will have better outcomes. And that's something that we can do to move towards that goal of fewer complications. Now, if you're looking for fewer complications without a scar, this is also important. Which technique should you use? Should you use the retroauricular? Should you use the transaxillary? Should you do the transoral? This is a paper that we published with Tulane University where we looked at our outcomes using either the transaxillary or the transoral approaches. And you can see that we had no permanent recurrent laryngeal nerve palsies and no permanent hypoparathyroid patients. And as you think about how we can avoid complications while still moving forward with eliminating scars, with eliminating pain, these are things that we can step along the path, steps that we can take along the path. These are some of the cases that we have done at Hopkins. We're now over 300, where we've been able to do a wide range of patients, even patients that are very overweight, which we sometimes have in the United States. And you can see that our operative times are improving. Some of the things that we can use to help us avoid complications as well is to do things like using imaging for parathyroid glands. This is a picture of the flow beam, which is something that we are beginning to appreciate the value that it adds. Some of the intrinsic properties of parathyroid glands in the future, as they become more readily available on the field for surgeons, have the opportunity to help surgeons know which patients they need to auto-transplant tumors in, and really what we need to do to help our patients to avoid as many complications as possible. Now, going back to avoiding a scar and trying to talk about that, one of the things we have been interested in is trying to figure out if it even matters to patients whether or not they have a scar. And this is one of the earliest papers, of course, came from South Korea, where the authors, Dr. Choi and colleagues, found that having a scar, even if it heals well, affected the health-related quality of life as much as psoriasis, vitiligo, or severe atopic dermatitis. That was a very important study for us in letting us know that maybe patients care about scars. However, in the United States, there are many people who say that a scar doesn't matter and that maybe our patients are different than the patients elsewhere. And so that's why it was very happy for me to see that one of the, or rather the most concerning complaint for patients after surgery, the number one adverse effect of thyroid surgery, was the appearance of the scar. And so this is from Dr. Sturgeon, who's a surgeon in Chicago, really corroborating that patients do care about having a scar. And so as we try and avoid any complication for patients, we need to be thinking, how can we do this safer? How can we do this without a scar? What value can we add to our patients? And so one of the questions we had was just exactly about the value. Maybe it's not worth avoiding a scar because maybe it's just too hard to learn. And so we took a number of pictures and we showed pictures to random people, and the pictures, some of them had a scar and some of them did not have a scar. And when we asked these casual observers what they thought about the pictures, we found that patients who had a neck scar were perceived to be less attractive. They were perceived to have a lower quality of life. And when we asked these patients, or not these patients, but these people, how much they would pay to avoid a scar, they said that they would pay on average more than $10,000 to avoid a scar. And so that showed us that some people care about having a scar. Then we also took other people and we showed them pictures of patients that did have a scar and patients that didn't have a scar. And then we looked at where their eyes went. We used infrared eye tracking. And what we saw was that when you have a scar, your eyes focus down here. And so we want people to look us in the face when we're talking to them. But if you have a scar, instead we find that your eyes will be drawn down and you will look at the neck more than you should. This is a heat map on the woman in the black shirt. You can see that she had a thyroid scar, and even though it healed well, the eye is drawn down to look at her scar. The woman in the middle, you can see that people don't even look down at her neck, but she actually had a scarless thyroid surgery. And the woman on the right, well, she's especially interesting. All she has is a small mole, but just the presence of that mole is enough to draw people's eyes down to the neck. And so it shows us that maybe there is some value in avoiding a scar. Now, another thing that's important is we would like to do this with as little cost as possible. In this perfect world, the goals that we're working towards. And for us, in our hands, we were able to find that scarless thyroid surgery, the price of this surgery is roughly equivalent to the price of normal thyroid surgery. And then we want to be able to treat as many patients as possible. We don't want to treat all of these patients with these wonderful techniques and only be able to treat 1 or 2 patients each year. And so we looked at the indications for transoral thyroid surgery, and we found that a vast majority of our patients are actually candidates for this surgery. And that's not just at Johns Hopkins, but also at other academic centers across the United States. And it is, at this point, just about half of my practice, which, as we suggested in this paper, is about what it should be, that about half of all patients are candidates for a remote access thyroid surgery that doesn't have a scar and has very few complications. So again, these are all things that move us towards Dr. Bones and helping Dr. Spock, but they're still all with a scalpel. We still have to help our patients with a scalpel. And so we're looking for things that we can do without a scalpel. And one of those things that we've come upon recently is radiofrequency ablation. And radiofrequency ablation requires a shift in thinking on our part. We have to think of ourselves as interventionalists instead of just as surgeons. And that we need to be the people that know the anatomy and know the techniques and have everything in our toolkit to be able to offer our patients so that we can help them with whatever problem they might have. I would encourage each of you to consider radiofrequency ablation as a technique. This is why. This is a slide from my dear friend, Dr. Rangel in Brazil. And it's a slide that demonstrates the value of radiofrequency ablation in reducing symptoms and suggests that a preponderance of evidence adds together to say that radiofrequency improves the symptoms of patients with benign thyroid nodules. This is a publication in 2013 that demonstrates that when you use radiofrequency ablation on a 10-point scale, patients will have an improvement from almost 4 in their symptoms to less than 1.5. And so symptoms improve when you treat patients with radiofrequency ablation. Next, we also can see that their cosmesis improves and that these nodules become less visible and less notable to other people and themselves. We know that it is happening. There are cancers that are being treated with radiofrequency ablation as well, and that in the future this may become even a broader option for patients who have small cancers that we would otherwise observe. And certainly we hope to be able to demonstrate whether or not there is any benefit for these patients. And so in conclusion, let's remember that our goals as we're making these steps along the way is that we want to treat only the nodules that will affect morbidity or mortality. And we want to heal patients with as few complications, with as few scars, with as little pain, and with as little cost as we can for as many people as possible. And as we try and do those things, it's going to take steps along the way, and that's what this meeting is all about, is about chances to work together and lead as we really move forward into the next steps. And I think I would challenge you all to remember that sometimes when we think we know something, it actually makes it harder for us to invent and to discover. And so certainly remember that we don't know everything, and until we get to that perfect place of being able to fix everyone without a scalpel, well, there's still more things that we can learn. And until then, thank you for the chance to present, and thank you for all of your time. Hopefully next year we can meet together in person. So be well until then. Thank you.